Hey, have you ever been to the doctor, got a shot in your knee, and walked out thinking, wait, what did they just put in me? Like, you knew something happened. You felt the needle, you signed the consent form, but nobody really explained what it was, why you were getting it, or whether it was even the right choice for you. And asking felt awkward, right? The doctor looked busy, the appointment was already running long, so you just nodded and left. That feeling? That's exactly what I want to fix today. Hey everyone, welcome back. I'm a licensed pharmacist with 9 years of experience, and this is the channel where we break down dense medical research into plain, simple English. No jargon, no fluff, just the stuff you actually need to know. Today's topic, the top 4 knee injections used in orthopedic clinics, what they are, how they work, who they're for, and what the side effects look like. Now here's why I'm personally invested in this topic. My pharmacy is located right next to an orthopedic clinic, like wall to wall next door. So every single day, patients come in after their appointments saying things like, just got a shot in my knee. They gave me a different injection this time. Not sure what changed. Last time I had some swelling after. Hope that doesn't happen again. And honestly, as a pharmacist, I had to admit something. I didn't know as much about these injections as I probably should. Because here's the thing. Injections aren't really a pharmacist's domain. We deal with oral medications, topical creams, patches. What goes directly into a knee joint? That's the orthopedic surgeon's territory. But I hated just nodding along. 9 years of pharmacy experience, and I couldn't hold a proper conversation about knee injections? Unacceptable. So I did what any self-respecting pharmacist would do. I went and read the research, clinical guidelines, meta-analyses, expert consensus documents from European orthopedic societies. Today, I'm sharing everything I found, in plain English. Whether you're driving, cooking, working out, just throw this on in the background and let it sink in. One quick disclaimer before we dive in. Everything I share today is based on published research and clinical guidelines. It is not medical advice. For your specific situation, your knee, your history, your medications, please talk to your orthopedic doctor. They know your case in a way I never could from a script. All right, let's get into it.
Injection number 1. Corticosteroids, the fire truck. Let's start with the most commonly used knee injection out there. Corticosteroids. You might have heard it called a cortisone shot. I want you to picture something. Inflammation in your knee is like a fire. It's hot, it's swollen, it's painful, and it's spreading if you don't do something about it. A corticosteroid injection is the fire truck. It rolls in fast and it puts the fire out. Here's how it actually works. When your knee is inflamed, your body is releasing chemicals called prostaglandins and leukotrienes. These are essentially the alarm signals that say, something's wrong here, send pain and swelling. Corticosteroids block those signals at the source. The alarm gets shut off, the inflammation settles down, and your pain drops, sometimes dramatically. How fast does it work? Fast. We're talking 24 to 48 hours in many cases. I had a patient, a woman in her early 70s, who came into the pharmacy the day after her cortisone shot. She said, I forgot what it felt like to walk upstairs without holding the railing. That's the fire truck doing its job. How long does it last? Anywhere from 4 weeks to 3 months, depending on the person. But here's the catch. You can't keep calling the fire truck. If corticosteroids are injected into the same joint too frequently, research suggests they can actually damage the cartilage over time, the very thing you're trying to protect. Most guidelines recommend no more than 3 to 4 injections per year in the same joint, and many experts say you should wait at least 3 months between injections. One more thing, if you have diabetes, pay attention. Corticosteroids can cause a temporary spike in blood sugar. It usually resolves within a day or two, but it's worth monitoring closely if you're diabetic. Who is this injection for? People with acute, sudden flare-ups. Your knee ballooned overnight. The inflammation is severe and you need fast relief. That's when the fire truck gets called. Injection number 2. Hyaluronic acid, the shock absorber. You might have heard this one called a gel injection or viscosupplementation. I like to call it the shock absorber shot. Here's why. Your knee joint is surrounded by synovial fluid. This fluid acts like a natural lubricant and cushion. It keeps things moving smoothly, and absorbs impact when you walk, run, or climb stairs. In a healthy knee, this fluid is thick and gel-like, but when osteoarthritis sets in, the fluid gets thinner, more watery, the cushion breaks down, and bone starts grinding against bone. Hyaluronic acid injections essentially top up what's been lost. Your shock absorber is worn down? Let me put a new one in. Compared to corticosteroids, this is a slower burn. The fire truck arrives immediately, but putting in new shock absorbers takes time. Most people don't notice a significant difference until 3 to 4 weeks after the injection, but when it works, it can last 6 months to a full year. Brand names you might recognize: Synvisc, Euflexa, Monovisc, Durolane. They differ in molecular weight. Higher molecular weight generally means thicker fluid and potentially longer lasting relief. How many injections do you need? Depends on the product. Some are a single injection, others are a series of 3 to 5 weekly injections. Cost varies quite a bit, anywhere from $50 to several $100s per injection, depending on where you are and which product is used. Insurance coverage also varies, so it's worth checking. Who is this for? People who want longer-lasting relief without repeatedly going back for cortisone shots. It tends to work best in mild to moderate osteoarthritis. Fair warning though, the response to hyaluronic acid is highly individual. Some people feel a remarkable difference, others feel nothing. Earlier stage arthritis tends to respond better.
Injection number 3, PRP, your own blood, supercharged. Okay, this one sounds a little sci-fi, but bear with me. PRP stands for platelet-rich plasma. Here's what happens. They draw a vial of your own blood, put it in a centrifuge, basically a spinning machine, that separates your blood into layers, and they extract the layer that's densest in platelets. Why platelets? Platelets are the components in your blood that rush to a wound and help it heal. They release what are called growth factors, signalin proteins that tell surrounding tissues to repair themselves. So the idea is, take those healing signals, concentrate them, and inject them directly into the damaged knee. Body, here's a mega dose of your own repair kit. Get to work. Because it comes from your own blood, the risk of allergic reaction or rejection is extremely low. That's part of why it's been marketed as a natural or regenerative therapy. Now, full transparency here. PRP is one of the most debated injections in orthopedics right now. Some studies show it outperforms hyaluronic acid and corticosteroids, especially for younger patients with mild to moderate arthritis. Other studies, particularly larger, more rigorous ones, show results similar to a placebo. Here's the key issue. There's no standardized way to make PRP. Different clinics use different centrifuge speeds, different platelet concentrations, different injection protocols, so comparing studies is genuinely difficult. A 2024 European consensus from orthopedic specialists came to this conclusion. PRP is appropriate for patients under 80 with mild to moderate arthritis, Kellgren-Lawrence grade 0 to 3, who have already tried other injections without sufficient relief. It is not considered appropriate as a first-line treatment, and it's generally not recommended for severe arthritis, grade 4. Cost-wise, anywhere from $500 to $2,000 per session in the US, and it's typically not covered by insurance. In Europe, costs vary significantly by country. Bottom line on PRP? Promising but not yet proven by large, high-quality trials. If you're considering it, have an honest conversation with your doctor about the evidence and the cost. Injection number 4, Prolotherapy, the provocateur. This one is probably the least well-known of the 4. Prolotherapy, also called proliferation therapy or regenerative injection therapy. What goes in the needle? A high-concentration dextrose solution, basically a highly concentrated sugar water solution. I know, it sounds almost too simple, but there's a logic to it. The idea is counterintuitive. You're deliberately causing a mild inflammatory response at the site of injection. By irritating the tissue slightly, you're essentially tricking your body into thinking, hey, something's wrong here, time to send in the repair crew. Your body responds by activating fibroblasts, cells that produce collagen. Collagen strengthens ligaments and tendons. Over time, the tissue becomes more stable and resilient. If corticosteroids put out the fire, prolotherapy intentionally strikes a small match and lets your body's own firefighters do the real work. Who is this for? Primarily people with knee instability, lax or weakened ligaments, or chronic diffuse knee pain that hasn't responded well to other treatments. Cost is generally lower than PRP, roughly $100 to $300 per session and varying by location. Important caveat though, the evidence base for prolotherapy is thinner than for the other 3 injections. Research is ongoing, results are mixed, and not all clinics offer it. It's generally used as a complementary approach, not a standalone first-line treatment.
All right, let's bring it all together. 4 injections. Quick recap. The fire truck, corticosteroids.
Fastest acting. Shuts down inflammation quickly and effectively. Best for acute flare-ups. Limit to 3 or 4 times per year. Minimum 3 months apart. Watch blood sugar if you're diabetic. The shock absorber. Hyaluronic acid. Replenishes the joint's natural cushioning fluid. Slower to work but longer lasting. Best for mild to moderate arthritis. Response varies significantly between individuals. The supercharged blood, PRP, uses your own platelets to stimulate healing, promising results in some studies, mixed in others. Best considered after other injections haven't worked. Not recommended for severe arthritis or as a first treatment. Higher cost, rarely covered by insurance. The provocateur, Prolotherapy. High concentration dextrose triggers natural tissue repair. Weaker evidence base compared to the others. May help with ligament laxity and chronic instability. Lower cost, but not universally available. Now, here's something I want to say directly. I put this video together because patients deserve to understand what's being put into their bodies. Walking into a pharmacy after a procedure and not being able to have a real conversation about it didn't sit right with me. You got a cortisone shot? Okay. Just a heads up, if you're on any blood thinners, keep an eye on the injection site. Hyaluronic acid? Give it a few weeks before you judge whether it's working. That's the kind of conversation I want to be able to have. But I want to be completely clear about something. I am a pharmacist, not an orthopedic surgeon, not your doctor. The people who truly know which injection is right for you are the clinicians who have examined your knee, reviewed your imaging, and spent years treating patients exactly like you. They've read more literature than I have. They've seen the outcomes firsthand. Their clinical judgment is built on experience that no amount of research papers can fully replicate. Today's video is meant to help you walk into that appointment a little more informed, so that when your doctor says, "I'd like to try a corticosteroid injection today," you understand what that means, and you can ask better questions. That's it. That's the whole goal. If there's a specific injection you've been given and you want me to dig deeper into the research, drop it in the comments. I read everything, and it might become the next video. If this was helpful, hit subscribe and leave a like. It genuinely helps more people find this content. Thanks for watching. I'll see you in the next one.